Good afternoon, everyone, and thank you for joining us for today's webinar, Pediatric Enteral Nutrition in the Community, Part 1, Tolerability of Formulas Containing Real Food Ingredients. I'm Lauren Murch, Medical Affairs Manager at Nestle Health Science, and I'm your moderator for today's session. Before we get started, I have a few quick housekeeping notes. Today's session is being recorded, and after the session, you'll receive a certificate of attendance and a link to the recording. Financial support for this presentation was provided by Nestle Health Science, and the views expressed herein are those of the presenters and are accurate as of the day it was presented. On the right-hand side of your screen, you should see a button for Q&A. You can enter your questions into the Q&A box, and we'll do our best to get to as many of them as we can. Anything we don't get to today, we'll try to address in Part 2 of this webinar series. I'm honoring the land that we are presenting on today. We respectfully acknowledge that the Nestle offices across Turtle Island are located on the traditional treaty and unceded territories of First Nations, Inuit, and Métis people. Indigenous people share a sacred relation with the land, and this acknowledgement is only the first step in learning more about our history and taking action towards reconciliation. Now, I'd like to introduce our speakers for today. Inez Martincevic is a clinical dietitian in the Division of Gastroenterology, Hepatology, and Nutrition at the Hospital for Sick Children in Toronto. And Dr. Jessie Hulst is a staff gastroenterologist in the Division of Gastroenterology, Hepatology, and Nutrition at the Hospital for Sick Children, and an associate professor in the Department of Pediatrics and Department of Nutritional Sciences at the University of Toronto. And now I'll turn it over to Dr. Hulst for today's session.
Thank you very much, Lauren, for this kind introduction. It's our pleasure to present today in part 1 of the two-part webinar series on tolerability and use of formulas containing real food ingredients. Today we'll be focused on the results of an intervention study we performed at the Hospital for Sick Children. So these are our disclosures, and also to say that the study we did was supported by Nestle. Before we start talking about the results, I would really like to acknowledge our colleague Alyssa Ramusak, who is a research dietitian, and she was our amazing study coordinator and lead, and she has created some of the slides and figures. And I would also like to thank the participants and the participants' caregivers for participating in the study. So today's objectives are to review recent evidence for tolerability of formulas containing real food ingredients in stable medically complex pediatric patients. Also to discuss implications to practice in hospital to home settings in the context of existing evidence supporting blenderized tube feeding. And this will continue in part 2 of this webinar series. And also at the end of today, we will introduce a needs assessment for challenges in pediatric enteral nutrition in the community. So first, a little bit of background, and as you all know or hear about, I think, is that there's a growing interest in the use of food-based feeds among pediatric tube-fed children, and the overall term that is used is blenderized tube feeds. It can also be referred to as blended foods or liquidized tube feeds or blenderized food or diet or homemade blend formula. So there's lots of terms there. And in general, blenderized tube feeds can be homemade, hospital made, or commercially prepared. And they are composed of foods and liquids that are blended into a consistency that is able to be delivered via a tube. Currently, there's no universally accepted kind of terms for describing all the different types, but the literature has proposed the category as you can see on the screen. So the overarching term is blenderized tube feeds, and then there is the home blenderized tube feeds. This is like food prepared at home by caregivers. Then there is the commercial blenderized tube feed or CBTF, which are blended whole foods and liquids described as, for example, whole food ingredients or 100% real food meals of blenderized whole food tube feeding. And then there is the third category of commercial food-based formula, which often include like polymeric or hydrolyzed enteral formula, but then with added whole foods or food-based ingredients. Some examples are, for example, rehydrated chicken or fruit purees. So these commercially available products are convenient, ready-to-use alternatives for home blend feeds. So now we wanted to talk a little bit about what are some clinical outcomes related to the use of blenderized feeds, and research has mostly focused on the outcomes on home blenderized feeds, and only few studies have included the other types. But in general, in terms of gastrointestinal symptoms, the studies have shown that the use of blenderized tube feeds can be associated with improved GI symptoms such as gagging and retching, less vomiting, improved nausea and reflux symptoms, and also a change in bowel movements and less abdominal pain. In some of the studies, it was shown that constipation could also worsen, and that's why it's important to keep an eye out for that and adjust medications as needed. Other health effects that have been kind of studied in small like retrospective and small prospective studies is that it can change microbiome, and changing microbiome will then usually increase the gut microdiversity, which can have a beneficial effect on like stooling patterns. Overall, also the oral intake in children who are able to eat orally, there has been suggestion that children tend to eat more orally when they're on blenderized feeds compared to the like normal tube feeds, and then reduced kind of outcomes such as ER visits, hospital admissions, and less medication use. So that's likely associated with better control of the GI symptoms. Then in terms of growth, that's a little bit limited often because it's only there's often short time studies, but improvement in weights and height have been reported. But on the other hand, also weight loss has been reported. So it's very important to kind of have follow-up closely in children on blenderized feeds. But in some of the like guidelines from like our like professional bodies, they have been a bit hesitant, mostly related to long-term growth outcomes and micronutrient adequacy. So in terms of nutritional adequacy, of course, there's variation in the composition, especially with the home blends and some of the other commercially available ones. The CFBF, so the commercial food-based formulas, they are complete nutrition for children aged 1 to 13, and 100% of kind of the DRI for the macro and micronutrients should be possible, but of course that depends on the volume and calories needed as well. And lots of studies have reported on like caregiver experience, and I think that's also usually the drive to try to go to blenderized feeds, is that they have overall improved quality of life. The child and the family, the well-being of the child is improved, more satisfaction around feeding and feeding times, more normalcy, so to be able to give more normal food is very important, and it can empower like caregivers to care for their children. Also, in a blenderized diet, familial or cultural or religious beliefs could be incorporated in the choice of foods. So now moving on to the study, as I said, there's limited studies evaluating the effects of commercially prepared food-based formulas, especially in medically complex children. So our kind of objectives are related to that. So we know that the commercially available may have the same benefits, but the research has been really sparse. So in the study that we're presenting, the first objective was to assess the gastrointestinal tolerability of the complete junior 1.5 formula, and this formula is a plant-based formula with hydrolyzed pea protein with added L-cysteine. It's also hypercaloric with 1.5 kcal per ml. It's a real food-based formula and it's ready to feed. And the second objective was to assess nutritional adequacy, and how we did these is for the GI part, we looked at the frequency of vomiting, gagging and retching, and gastric venting, and also the stool type and frequency. And for the objective number 2, we looked at weight changes, if the percentage of goal energy and goal proteins were met, as well as the DRI for the other nutrients. So in terms of the study, so this slide depicts the study overview. So it was a single arm, open label prospective study. It started in May 2023 and we completed data inclusion in June 2024. The participants were medically stable ambulatory pediatric tube-fed patients at the Hospital for Sick Children, and we recruited from various departments, so our GHN the department, but also cardiology and pediatric medicine or complex care patients. So in terms of inclusion criteria, so the age of the children included was 1 to 13 years, which aligns with the formula. The patients had to be medically stable, tolerating their enteral feeds. And also it was important to note that the enteral feeds were supposed to provide more than 90% of the nutritional needs, so highly dependent on tube feeding. The type of tube that was allowed in the study was all types of tubes, so nasogastric, G-tube, GJ tube, or combination tubes, or like surgical J tubes. And we included patients, or we intended to include all patients even with an 8-inch or higher French size of the tube. This was done with intent to try to address the gap in the literature to assess tube blockage or obstructions. In the literature so far, most studies would advise 14 French or more. Also in terms of feeding mode, so if it was continuous or bolus feeds, any type was allowed, and also a combination of modalities. So in terms of the overall study design, we had a baseline visit, then a transition period, the study period, and the end of study visit. And the different visits included different like parameters that we obtained. So at baseline, of course, we looked at the demographic, the background of the patient, physical exam. We did the standard anthropometrics, weight and height or length. And we looked, of course, at the current kind of nutrition the patient was getting, and then calculated like what would be needed to transition to the study formula, with the aim to keep it isocaloric. And for fluids, we would add more water, because of course if you go from a 1.0 to a 1.5 in terms of calorie, the volume would be less. And this is also one of the reasons that in a lot of these patients they're volume sensitive, but especially volume sensitive to formula, that there might be a benefit to go to a higher concentrated feed. So in the transition period that was intentionally done, we wanted to get a sense of their baseline kind of tolerance. So 2 days we observed on the usual feeds, and then there were 3 days of transitioning to the study formula. And this was done with intent to kind of slowly ease into the new formula. So we took 3 days, every day 25% of the study formula was kind of increased. So the first day 25, 75, 50, 50, and then towards 100% on the first day of the study period. And then they spent 14 days on this study formula, and the caregivers were then instructed to collect a lot of data every day. This was through an e-platform about how much feeds were administered, how the tolerance was, symptoms, bowel movements. And so that was, of course, a bit intense, but it was really well done by the families. And then at the end of the study, we got another weight, and the caregivers also filled out a satisfaction survey. And then we also, of course, made a post-study nutrition care plan, so either to continue on the study formula or help them to go back to their previous one, depending on their preference. So just to show, because the stool were scored based on consistency and frequency, and these are well-known stool scales, but I'm not sure if you're familiar with them, so I showed them here. So parents would fill out every day what type of stool was produced. And then you have the Bristol stool scale. This is for patients who are like continent for their bowel movements, versus the Brussels stool scale for children still using diapers. For the statistical analysis, we used descriptive statistics and the Wilkinson sign ranked tests to kind of compare baseline and end of study parameters, as you can see here. And for the energy and protein, we calculated the amount received over prescribed and then also related to the DRI. And we did pair t-tests to compare baseline versus average intake during the study. So then moving on to the results. So 27 participants were recruited, with 26 completing the study. 59% were boys and 11 girls, and the median age was 5.5 years. The primary diagnosis groups were largely in the genetic congenital area, 51.8%, or neurologic conditions, and the median number of medications that these patients were on were actually quite high, 8. So that shows that it was a complex population, with polyethylene glycol as the most common medication. So that's used for constipation or regulation of bowel movements. Then in terms of feeding, most children were fed by a gastrostomy tube, so 81.5%. None of them had an NG tube, and 4 had a GJ, and 1 had a J tube. And then in terms of the mean baseline formula density, so their formula that they were on before the study, the concentration was 1.1 kcal per ml. And then the type of formulas that were used at baseline was 9 were already on a commercial food-based formula, but not high concentrated, 5 on amino acid based, and 3 on mixed type of formulas. So those were the top 3. And all the children in terms of their tube had a 12 French or higher. So we did not have any patients that had a smaller French size. So in terms of gastrointestinal symptoms and bowel movements, there was no significant difference found between baseline and the study period for all of them, actually: vomiting, gagging and retching, and gastric venting. And there was also no significant difference between bowel movement frequency at baseline and during the study period. In terms of weight and BMI, so this is expressed as Z-score. So that's, I think most of you will be familiar. It's similar to percentiles, but it shows like how far you're off from the population mean. So you can see here that at baseline, I can try to use my pointer. Yeah, so at baseline, the weight for age was minus 1.75, and at the end of the study, it increased to minus 1.67, and BMI also increased from minus 0.6 to minus 0.48, and these were statistically significant here. Also, if you look at energy and protein requirements and how that was achieved, so the participants achieved 100% of the prescribed energy for nearly all the study days and exceeded their daily protein requirements. So that was as expected, but it's nice to show here. In terms of the other kind of nutrients that are that we studied, we looked at their baseline formula and also at the study formula. And you can see here on the x-axis all the different nutrients, and you can see on the y-axis how they met kind of the DRI. And the red line shows 100% of the DRI. And you can see that most of the nutrients were provided in excess, both on the baseline and study formula, and some are below, as you can see here. So what we saw that for fiber, vitamin K, choline, sodium, potassium, and chloride, there were significant increases on the study formula. And for like carbohydrates, vitamin E, B5, B6, B12, folic acid, vitamin C, it was lower than what they had at baseline. But still, for many, it was high. You can see for fiber that's it significantly went up, but is still far below the DRI for baseline and study formula, as well as the electrolytes. And we can talk more about that if needed. So in terms of the caregiver's perceptions, which is of course more and more important as study outcomes as well, is that most caregivers were really satisfied, like 53.8%, or very satisfied, almost 31%, with the study formula. They reported similar frequency of vomiting, constipation, and gagging and retching, so similar to what we found based on the diary every day. When we asked if they wanted to continue the formula, almost 77% wanted to continue, and that was kind of based on, even though in their similar frequency, they felt that there was improved bowel movements, weight gain, and a higher calorie concentration they liked. So in terms of our key findings, we can state that after 14 days on a hypercaloric plant-based real food ingredient formula in medically complex stable tube-fed children, they experienced no change in GI symptoms, weight gain, they met their protein and energy goals, and they met more than 100% of DRI for most macro and micronutrients. Some of the strength and limitations. So in terms of strength, we feel this was a heterogeneous sample from different clinics. Another strength is that it was a prospective design and not like retrospectively looking in children who had been changed for some reason. There was a high retention rate, only one dropout, and the patient who dropped out actually already dropped out before the study formula was actually started in full, and was related to like an upper respiratory tract infection, and the product was highly accepted, and it also addresses one of the research gap to do more studies with this type of formula. Of course, there were also limitations. It was only one center that we did the study. The sample size is quite small, and we didn't have a control group. And the study period in itself, 14 days, maybe enough to look at weight, but it's not enough to look at like linear growth. And that is one of the questions I think you can have on a plant-based protein, if the linear growth is consistently going well. So that's also a question we have for the future. And then another limitation may be that there was a subjective tolerance. There was subjective that we asked the families to report it. So I hand over to Ines now to talk a little bit more about considerations for practice.
Thank you kindly, Dr. Hulst, and for the opportunity to segue into what would be part 2 of the webinar. So while the review of the data outcomes is very important and it adds to the growing body of knowledge and evidence as it relates to tolerability of medically complex and or maybe not even complex, but tube-fed children on blenderized tube feeds, we also think it adds layers to the practical considerations, and some of the layers that frontline staff and clinicians might encounter when either thinking about initiating blenderized tube feeds or following patients that are already receiving such. Certainly one consideration is candidacy, and this gets discussed often. There might be an interest among caregivers to deliver blenderized tube feeds, but whether medical appropriateness or whether knowledge and understanding in certain patient populations is available is often a consideration. Knowing what the nutritional needs might be, as well as evaluating that nutritional status, is integral, and reflecting on psychosocial needs. Can caregivers administer blenderized tube feeds, and what are some of the implications if the interest is there, but the feasibility or the resources aren't? The other clinical consideration, of course, is around the actual tube and tube feed and feed schedule considerations. So often the literature reports tube size, as you had highlighted, Dr. Hulst, of a 14 French bore, but in clinical practice, we can say anecdotally, there's evidence to say that smaller size tubes can handle blenderized tube feeds, and that there can be applications to such, whether homemade or commercial feeds, to facilitate the administration of food-based, real ingredients feeds, including the modality. So the schedule, is it continuous? Is it bolus? Is it intermittent? Are we feeding in the stomach? Are we feeding post-pylorically? Can we use a pump? Other than syringes, what other tools are available? And that overlays into the actual feed type. There's often a lot of discussion around food safety. So preparation, storage, not just administration, looking at things like thickness and viscosity, particularly as it relates to risk of tube blockages, hang times, cleaning, and then that just continues to overlay into what frontline staff experience frequently, which is how often do children on blenderized tube feeds need to have follow-up? How frequent is it? Who are the clinicians that need to be assessing? How much of it is hands-on versus virtual? When do we need to do labs? And I would say one consideration that sometimes always isn't readily available, particularly as we talk about collaboration and collegiality with respect to providing nutrition care and support from hospital settings to the home and in the community, which is the concept of an emergency feed plan. What happens if families and caregivers travel, or if there is an intercurrent illness, episodes of feed intolerance? What can be done to mitigate concerns as it relates to options around managing blenderized tube feeds? Next slide, please, Dr. Hulst. And so what we do realize is there's information out there, but clinicians and their perspectives are asking for more, not just data about outcomes related to health and nutritional considerations, but also how to safely, effectively, and with confidence initiate, transition, and feed using blenderized tube feeds. So we do know that surveys across the globe have highlighted registered dietitian perspectives with blenderized tube feeds, as well as colleagues including nursing and medical staff. So while we can acknowledge that caregivers are very interested, and we know that there's evidence to support the administration of various forms of blenderized tube feeds, there seems to be a sense of a lack of resources, limited information, training, and an understanding around follow-up and monitoring, when to intervene, when to continue, how to pause, how to deal and help families when they're having difficulty with episodes of feed intolerance again, as well as clinical concerns around knowing how to do a nutritional assessment when you don't know the composition potentially of feeds, how to deal with tube breaks, tube blockages, and this overarching big question around infection risk, which continues to linger even in the literature. Next slide, please. So in summary of part one of this webinar, we do hope that the study that was conducted here at SickKids has demonstrated that there's tolerability for a hypercaloric, plant-based, real food ingredient formula among tube-fed children with medical complexity, but that we've highlighted there's only some guidance available to clinicians around safe and effective administration of blenderized tube feeds, and that this may impact how such feeds are administered in the home and in the community. So we acknowledge that more research is needed to better understand both long-term health outcomes around real food ingredient feeds, but also information and evidence to support the clinicians that are guiding such feeds in practice. And so we really, really strongly encourage everyone who joined us today for this webinar to collaborate with us. We acknowledge that we have a needs assessment out there, and we really would like to know how we can help support real food-based and blenderized tube feeds in the community, thinking about things like support, resources, managing caregivers, questions, expectations, tools, medical advocacy, anything that you can think of that might be able to support this in the community. And we strongly encourage everyone, invite you all to complete a need survey that will actually be data that will be used by Dr. Hulst, myself, and the collaborators for part 2 of the webinar to very much target information that we can share with each other and support blenderized tube feeds for children. And so I do believe we have a few minutes to welcome some questions and hear from the audience and get some feedback.
Yeah, we have a couple of questions in the chat. I know we're at 1:30, but we'll try to address 1 or 2 of them, and then whatever we don't get to, we can address next time. Just a note, also, I did paste the link to that needs survey into the chat as well, so you can access it either through the QR code or through the link in the chat. One question we had was if volume of feeds decreased with the higher concentration, or did you give the same volume during the study? And if volume was decreased, did parents have any observations on spending less time on tube feeds?
Ines probably wants to take this one.
Yeah, definitely. So the feed volume was decreased. We did address TFI by giving caregivers the opportunity to either add water unless there was a medical indication for another fluid, such as an oral electrolyte solution. But essentially, the majority of the participants had water that was added either at the time of the feed or throughout the day, primarily as boluses, even if the patient was being fed post-pylorically. So as it related to water administration. And yes, to answer part 2 of that question, that did facilitate less time that was associated with administering a feed, which was part of the end of the study survey that caregivers answered for us. And one of the indicators as to why they wanted to continue on a hypercaloric food-based formula.
Thank you. Another question we have was, did you supplement nutrients such as sodium to meet DRI, or did you leave the levels to what was provided by the formula?
Yeah,
I think that's a 2-parter. Yeah, Dr. Hulst, if I can let you know, we didn't supplement.
No, we didn't supplement. We also didn't check levels. I think when we, like in my clinical practice, I see a lot of children on long-term tube feed, any type of tube feed, and we do nutritional labs, including electrolytes, kind of once every like 1 to 2 years if they're stable. And sometimes we do see not so much in the blood actually low sodium levels, but it would be more in the urine. If you see that the urine is sodium is low, that they're trying to hold on to it. And so it's not kind of unusual to sometimes see that, but most of the time the blood levels are normal. And I think well, maybe Ines can better speak to it, but there's a reason not that it's not all like meeting DRI, more from like the food industry perspective.
Yeah,
Ines,
so one of the things to highlight when we did do the review of the nutritional composition was that it was comparable to baseline formula. So there was a variety of formula that the participants were on, including some food-based formula as well as standard polymeric, hypercaloric polymeric, amino acid, extensively hydrolyzed. I mean, it was really a mixed bag. And one of the things that we did see was that sodium, potassium, and chloride are below DRI, but that's also with medical intent. And that is to say that if there are episodes where there is a medical intent to reduce fluid or to monitor sodium, the feed can still be administered. So much to what Dr. Hulst highlighted, and part of one of the gaps we think that might exist in the community around monitoring is there a need for more sodium? is the first question. And if so, how to administer it, knowing that if there is medical acuity in complex patients and or specific patient populations like cardiac patients, what can then be done with respect to, for example, removing sodium or potassium that was added to a feed, as opposed to reducing a feed and then compromising the remainder of the nutritional administration.
Yeah.
In the interest of time, I'll just throw one last quick question at you, and then we'll save everything else for the next session. Did you say at the beginning you included greater than 8 French versus just like a specific range? Can you just clarify that?
Yeah, well, the intention was to include patients with 8 French or higher, just to see, because we feel that could be possible, but none of the included patients actually had that. So it was not an exclusion criteria, but none of the participants, they all had kind of 12 French or higher. I think 8 French we typically see with NG tube, and none of the patients had an NG tube. They all had a G tube or GJ. So
Awesome.
that's an interesting future question. Ines did some, like, you know, her own kind of research and tried different tubes and with different formulas. And so we believe that we can use 8 French. We do it often, like all the children with other diseases. If it's only for feeding, that we do use 8 French NG.
Thank you. Well, with that, I'll close our webinar for today. So I want to thank both Dr. Halst and Ines for your presentations today, and thank you to all of our participants online for your engagement. As I said, I have pasted the link for that needs assessment into the chat, so we'd appreciate if you could do that. Also on the forms button on the left-hand side of your screen, there is a brief feedback survey, so we'd appreciate feedback on today's session. You will receive a link to the recording and an email with your certificate of attendance after this webinar. And this concludes today's webinar, and I hope you enjoy the rest of your day. Thank you so much.
Thank you, everyone. Thanks.